places in between. Okay. All right, well, let's get started. Welcome to the SADS Foundation's 10th webinar in our Living with SADS series. Tonight on pregnancy with a SADS condition. I'm Marcia Baker, Program Director for the SADS Foundation. And before beginning the webinar, a couple of reminders. Please keep your audio muted during the presentations to improve sound quality. Following the presentations, we have time for Q&A. You may type your question in the chat box anytime during the presentation, and we'll address the questions at the end. With 3 presenters today, you might want to add the presenter's name to whom your question is directed. That would be very helpful for us. Our webinar is being recorded today and may be viewed later on SADS YouTube channel. Now I'd like to introduce our 3 speakers in the order of their presentations. Dr. Danna Spears is a cardiologist and electrophysiologist in the Division of Cardiology at the University Health Network in Toronto, Canada. She obtained her medical degree at Queen's University and completed her training at the University of Toronto, including an adult cardiology residency and 3 years of interventional electrophysiology. She also completed subspecialty training in molecular cardiology in Pavia, Italy. Dr. Spears returned to Toronto in the Division of Cardiology and established the Heritable Arrhythmia Clinic with a clinical and research focus on many of the SADS conditions, such as long QT syndrome, Brugada, ARVC, and CPVT. Dr. Spears is also a cardiologist in the University of Toronto's Pregnancy and Heart Disease Program, where she manages arrhythmia disorders in pregnancy with a commitment to ensure safe and effective medical management of these conditions. Secondly, Anna Morales is a licensed genetic counselor in Ohio and works as a medical affairs liaison at Invitae. At Invitae, she specializes in diagnostic testing across cardiology, neurology, and pediatrics, communicating with clients and coordinating collaborations and publications. Prior to joining Invitae in 2019, she was an associate professor at The Ohio State University in the Division of Human Genetics for 7 years. She was also a board member of the American Board of Genetic Counseling, serving as its president for the 2019 year. Anna completed her undergraduate degree in biology at the University of Puerto Rico and a master's in genetic counseling at Brandeis University in Massachusetts. As an English and Spanish speaker, Anna has worked to expand access to genetic information in the Spanish-speaking community. Formerly, she practiced clinical genetic counseling in Puerto Rico and Miami, providing genetics and prenatal services to primarily Spanish-speaking populations. Our third speaker is Dr. Jeanette Strasburger, a pediatric cardiologist and electrophysiologist at Medical College of Wisconsin Children's Hospital in Milwaukee. She performs research in the area of prenatal evaluation of arrhythmias in the fetus. Dr. Strasburger received her Doctorate of Medicine degree and completed residency training at the University of Nebraska College of Medicine in Omaha. Her fellowships in cardiology and pediatric cardiac electrophysiology were completed at Baylor College of Medicine in Houston. Now I'd like to turn over the presentation to Dr. Danna Spears. Danna?
Okay, thank you very much. Please speak up if we're having any audio issues and you can't hear me. So I'm going to be discussing pregnancy in inherited heart disease, and I think that this will be a good segue into what the other speakers will be talking about. So we can just dive right in here. So I'd like to talk first about long QT syndrome. This is because we probably have the most data so far in terms of managing pregnancy in the inherited arrhythmia conditions from long QT syndrome. I think everyone here is probably familiar with this condition. There's 16 subtypes now and counting. It's the highest prevalence of the primary inherited arrhythmia conditions, with a prevalence of about 1 in 1,000 live births. And the most common phenotype is QT prolongation, with the risk of arrhythmia-mediated syncope or sudden death. In terms of pregnancy-related long QT syndrome outcomes, it first became apparent that pregnancy had a serious impact on the expression and outcome of this disease in the late 90s. When they first looked at the International Long QT Registry, they looked at 422 women who had their very first event in pregnancy. So I think this is really important to emphasize that pre-pregnancy, these women had no history of syncope, seizures, cardiac arrest. They were completely asymptomatic women. In pregnancy, about 1.8% of these women had an event, either a syncope or a cardiac arrest. But most alarmingly was that in the postpartum period, 9% of these women, again, completely asymptomatic women, almost 1 in 10 of them suffered an adverse cardiac outcome, meaning either syncope or a cardiac arrest. At that time, it was noticed that beta blockers had a very important effect on this outcome. So fortunately, it had been recognized for about 20 years by now that beta blockers were life-saving drugs in the management of long QT syndrome. And the most important thing here, I think, to notice is the significant reduction in the event rate in women who were taking beta blockers during pregnancy. Unfortunately, what I was going to say here is unfortunately only about 20% of these women were using beta blockers, but what they did see was that the likelihood of having a cardiac event after delivery was about 1 in 50 in women who were not taking a beta blocker, and that was reduced substantially to 1 in 2,500 women who were taking a beta blocker. So even in the late 90s, it was becoming extremely obvious that beta blockers were, again, a very life-saving intervention in pregnant women and women who were postpartum with long QT syndrome. About a decade later, they were looking at this again and starting to understand the impact of long QT syndrome and pregnancy and looking at genotype. First, I would just like to point out here, we talk about syncope and cardiac arrest. In the light blue squares here, you can see here, I'll just show this to you. This is pre-pregnancy, so women age 15 to about 9 months pre-conception. The pre-pregnancy stage, which is about 9 months pre-conception. 9 months post-delivery is the last one here, and then 9 months post-delivery to age 41, and then pregnancy, I think, is pretty obvious. So what they found here was that the risk of cardiac arrest or long QT death was about 4 times higher in the postpartum period than at any other time in these women's lives. So it is the first 9 months after delivery that is the period that we worry about the most. And we found also that when we started genotyping women, that the high rate of cardiac events, so you can see here, this is the postpartum period and the checkered lines, was dominated by women with the long QT type 2 genotype. However, this pattern remained in long QT type 1 and also in women who are not genotyped, so women who did not have access to genetic testing or where genetic testing did not reveal any significant gene variation. The women with long QT syndrome type 3, there were only 12 women of this subtype represented in this data, so it's difficult to make any conclusions about the numbers here. But I think it's just important to notice the event rates postpartum were so much higher than at baseline in women with long QT syndrome. And again, even when we understood the genetics of long QT syndrome a bit better, in all comers, the event rate was dramatically reduced from about 3.7 events per year in the postpartum period down to about 0.8 events per year. So a very significant reduction with the use of beta blocker. And again, even in 2007, you can see the numbers of beta blocker use at conception, at delivery, and postpartum. Only about a third of women were being treated with this life-saving intervention. So that brings me to a common question that I'm asked about, I think it's very obvious what to do with a woman who has long QT syndrome prepartum, during pregnancy, and afterwards. A beta blocker is absolutely indicated. But then we sometimes encounter the situation where the QT interval may not be entirely normal. There's no pre-diagnosis of long QT syndrome. There's not enough time to get genetics. And the question is, does this woman have long QT syndrome, and what should we do about it? And in our practice, what we do is, if we're in doubt, we do a low-grade exercise stress test to look at the QT response to exercise immediately. If it's completely normal, that can be very reassuring. If it's borderline, then we still will treat with beta blocker until about 6 to 9 months postpartum. And after this period, we will withdraw the beta blocker and complete a full exercise treadmill stress test to look at QT dynamics. If it's clearly abnormal, then we'll initiate beta blockade, consider genetic testing, and then proceed with neonatal and family screening. And this is something I think that Dr. Strasburger will discuss as well, is the importance of prenatal screening. And one of the main goals of this is to reduce perinatal intervention. So bradycardia due to a low sinus rate or high-grade AV block in utero may be interpreted as fetal distress rather than the recognition that this is actually fetal long QT syndrome. Ventricular arrhythmias can be managed in utero. And as well, the severity of phenotype in certain specific genotypes can be predicted by the sinus rates. So fetuses with severe bradycardia may have a longer QT interval at birth and more significant cardiac events after delivery. And the most important thing is to anticipate the need for a newborn ECG, to have the discussion around cord blood testing, and as well cascade screening for other family members. So the bottom line for the management of long QT syndrome in pregnancy is that beta blockers are absolutely indicated for arrhythmia prophylaxis. Telemetry, which is something I'll discuss a little bit more, is really only used in labor and delivery if there's a high risk phenotype. So if a woman has had a cardiac arrest or a history of severe arrhythmias, or very prolonged QT interval where there is going to be some concern about arrhythmia risk during labor and delivery. Avoiding QT prolonging medications is critical. Genetic testing, again, to assist with family and neonatal screening. Consideration can be given to cord blood testing at the time of delivery, and also to highlight the importance of neonatal screening after delivery and before baby heads home. So just a word on cardiac telemetry. So not all women need this, but we do recommend this in high-risk women. So this is a little telemetry pack, and it's attached to the stickers on your chest. And this is monitored 24 hours a day in the cardiac intensive care unit at our center, so that women in labor and delivery are having their heart rhythm, so not just their heart rate and blood pressure, but their actual heart rhythm monitored minute by minute while they're admitted to hospital if they're at high risk of arrhythmia. We'll move on now to Brugada syndrome in pregnancy. This is a much more rare condition and probably less recognized. It's important to know that the event rate in the case reports and case series reported in the literature is not increased during pregnancy. Unlike the non-pregnant state, syncope during pregnancy in a woman with Brugada syndrome is not as predictive of adverse outcome as a syncope may be in a woman who has a syncope outside of pregnancy, and that's a fainting episode. In the largest case series of about 200 women, there were no arrhythmic deaths. There was one sudden infant death, which was not determined in terms of the etiology to understand exactly what the cause of that infant death was, but it does highlight the importance of family screening and the recognition of a potential baby who may be affected. And what we do recommend is, if genetic testing is an option, to consider cord blood testing and also ECG screening of the infant. We also recommend consideration of aggressive fever management of both the mom and the baby, and avoiding provocative medications if the diagnosis is not clear. Other suggestions vary by center. So I've heard of other centers recommending AEDs at home, sleeping in the same room as the child. That's not something that we routinely recommend in North America, but I do know that some international centers have a different approach than we do. And so this may be recommended in some situations. Again, in pregnancy, an ICD is only indicated if there's a history of cardiac arrest or a faint or syncope that is considered to be likely arrhythmic. Genetic testing to assist with family and neonatal screening and cord blood testing can be considered. telemetry in labor and delivery if there's a history of arrhythmia. And in some centers, the recognition of a spontaneous brugada pattern is an indication for cardiac telemetry. That's not something that we routinely do at our center because the arrhythmia risk is so extremely low, but it may be a recommendation in your center. A vaginal delivery is certainly not contraindicated in Brugada syndrome. And when regional anesthesia is required, so you may be familiar with the recommendations to avoid sodium channel blocking medications, and these do include the local anesthetics. So we do have recommendations to minimize the dose and duration of exposure to that type of anesthesia, and also ECG monitoring if higher doses are going to be required. In terms of neonatal screening, arrhythmia complications in children are extremely rare, and this may be something that Dr. Strasburger may discuss in infancy and childhood, but we do recommend an ECG at delivery for what it's worth, even though, again, the phenotypic expression may be very different in childhood than it is in adulthood. Arrhythmogenic right ventricular cardiomyopathy. So this is one of the cardiomyopathies that we frequently encounter in pregnancy. And I just want to highlight, this was just published in 2020, the Nordic ARVC registry. So this was the largest collection of women with ARVC who were followed through to delivery. The prior studies had very similar results, but were much smaller cohorts of women. So this was 99 women who were carriers of pathogenic gene variants in ARVC in Denmark, Norway, Sweden, and Finland. And the bottom line here is what they found was that the number of completed pregnancies was not associated with any subsequent arrhythmia risk in ARVC. So this included women studied from 1 year after their last childbirth, and even women studied age 45 years and older who were gene carriers, so who had had children many years previously in many cases, did not have any increased arrhythmia risk. The other finding was that the degree of deterioration of right ventricular imaging characteristics, so right ventricular dilatation or right ventricular function, over time did not differ between women who had never had a baby and women who had had at least one baby. So it does not appear that having children affects your right ventricular parameters in terms of morphology or in terms of your arrhythmia risk in ARVC. No pregnancy-related ventricular arrhythmias were identified among women who carried a gene mutation for ARVC and who did not have a clinical diagnosis. And by that, I mean women who did not have pre-existing arrhythmias or structural evidence of disease, which would go along with their genotype. So these women were ones who had a normal ECG and normal echo and MRI prior to pregnancy. So being a gene carrier does not appear to increase your risk in any way. The bottom line here is that events during pregnancy and delivery and postpartum periods are extremely rare. In terms of women who have more severe disease, so structural disease or history of arrhythmia, the recurrence rates of arrhythmia in pregnancy tend to correlate with women who are not taking a beta blocker or women who have stopped their beta blocker during pregnancy. Those are the women who tend to be at higher risk for arrhythmia during pregnancy. Heart failure has been reported in about 2% of some case series, but this tends to occur in women who at baseline have major structural right ventricular changes before they get pregnant. And again, it's an extremely small percentage of women who run into this type of complication. Worsening of any of the right ventricular parameters during pregnancy is extremely rare. Beta blocker is recommended for women who have evidence of arrhythmia, so frequent PVCs or ventricular tachycardia. Some will suggest beta blocker in all patients who have any clinical diagnosis of ARVC, so any evidence of structural right ventricular changes or arrhythmia. Cesarean section rates do not differ in ARVC from the general population and is really only indicated in the setting of significant left or right heart failure. An ICD, again, is indicated in a woman who's had a prior cardiac arrest, severe left ventricular dysfunction, or ventricular tachycardia. Women who have had syncope, it's also an important question to ask whether this may have been an arrhythmic syncope or faint. Genetic testing, of course, is important to assist with diagnosis and with family and neonatal screening. And when you have identified a pathogenic gene mutation, it can be useful for cord blood testing to test the infant at the time of delivery. Unassisted vaginal delivery is considered only if there is severe left or right ventricular dysfunction, unless, of course, there are some concerns about baby that would mandate operative delivery. I recommend telemetry during labor and delivery only if there's a history of serious ventricular arrhythmia. Clinical neonatal screening is something that is something we discuss with our pediatric colleagues, but this disease typically manifests after the age of about 10 years old. And so screening of the newborn with ECG and echo may be impractical. However, again, if there is a pathogenic familial gene mutation, this can be helpful to identify a child who may be at risk later in life. A few words on hypertrophic cardiomyopathy in pregnancy. This is another condition that is fortunately better studied. It's a more common cardiomyopathy that we encounter in pregnancy. The good news is that most pregnancies are uneventful and maternal mortality is low. The most common events, such as heart failure or arrhythmias, are typically going to be seen in the last trimester or postpartum and can be seen in about a third of women who have worsening of their symptoms during pregnancy. This is most likely in women who have had signs or symptoms of heart failure before pregnancy. So it's important to identify with your doctor if you've had these types of symptoms to discuss pregnancy and pregnancy management, but it is certainly not in most cases a contraindication to pregnancy. The type of hypertrophic cardiomyopathy also does not seem to have an impact on the pregnancy outcomes. So whether you have an obstructive or non-obstructive form of hypertrophic cardiomyopathy, it doesn't seem to have an important impact. Preterm delivery is something, however, that is observed in a higher rate in hypertrophic cardiomyopathy. So in about a quarter of women, preterm delivery is seen. Unassisted vaginal delivery in most cases is recommended. So again, it's not an immediate indication for an operative or assisted delivery. Beta blockers in pregnancy are useful in women who have significant outflow tract obstruction or who have quite significant thickening of their heart muscle, more than about 15 millimeters, to prevent symptomatic heart failure. Beta blockers are also used to control arrhythmias. Calcium channel blockers can also be used as a second choice if beta blockers are not cannot be used or if they're not well tolerated. Atrial fibrillation is an arrhythmia that tends to come up more frequently with hypertrophic cardiomyopathy than with, for example, ARVC. This may not be well tolerated if you're pregnant, and cardioversion may be considered as a first-line therapy in that case. And anticoagulation, if atrial fibrillation occurs, is recommended to prevent blood clots from forming in the heart. Low-risk women with hypertrophic cardiomyopathy can undergo spontaneous labor and vaginal delivery. However, in higher risk women, so women with heart failure or severe outflow tract obstruction or more extreme hypertrophy, planned delivery may be recommended by your obstetrician. The severity of outflow tract obstruction will be an important thing to consider when your obstetrician is determining if epidural anesthesia will be a safe option for you. And oxytocin can also be used, but with a slower infusion than what we would normally use in women having a baby. CPVT in pregnancy. So this is one of the more rare inherited arrhythmia conditions. And as a result, we really don't have a lot of data. So there are a series of case reports really only in the literature. The message that is important to take from these case reports is that it is critical to continue your beta blocker throughout your pregnancy. While you're compliant with a beta blocker, there have actually been no reported events on women who are taking their full dose beta blocker. Exercise restriction is similar as recommended in the non-pregnant state. And how we manage women with CPVT at our center is to titrate the beta blocker every trimester. So we follow up and make sure that your heart rate and arrhythmia are well controlled in each trimester of pregnancy. And that's either, again, with a Holter monitor or even a treadmill stress test if we're very worried about you. The optimal management of labor and delivery is really unclear. Safe cesarean section has been reported in the literature, but many women have successful and uncomplicated vaginal deliveries. In general, in CPVT, the aim is to reduce circulating catecholamines, but also to ensure adequate beta blockades so that those circulating catecholamines don't result in arrhythmia. A lot of of women with these conditions will have a defibrillator or a pacemaker. And so this is something that's really important for us to manage appropriately during your pregnancy and labor and delivery. So in terms of what we're thinking about with your device is we want to know what kind of information we can get from your device to understand your arrhythmia. So have your arrhythmias been stable? Have you been having exacerbations of arrhythmia during each stage of pregnancy? We also want to make sure before you go into labor that your device is working properly. We want to make sure that if there are any battery or lead issues that we address those ideally before you get pregnant, but for sure before you head into labor and delivery. And how is labor and delivery or surgery, if a cesarean section is being planned, how is this going to work with your device? Pregnancy with an ICD is safe. The outcome in women who have defibrillators are related more to their underlying heart disease than it is to their defibrillator. So the outcome is related to your baseline heart function. And so women obviously are at higher risk if they have more severe left ventricular dysfunction. Women with arrhythmia indications for a beta blocker who stop their beta blocker tend to have more arrhythmia and more therapies or shocks from their ICD. Ventricular arrhythmias, again, are related more to a lack of beta blocker or non-compliance with beta blocker than to anything else. So really an ICD is a very safe way to manage your arrhythmias during pregnancy, and it's not something that we worry about. Telemetry is recommended if you have a recent history of poorly controlled arrhythmia. So you're protected by your device, but ideally we would like to know what's happening with your heart rhythm before your device has to intervene. We will check your device usually in the last trimester again, just to make sure that the lead and battery integrity are okay. And we also look for arrhythmia logs, so ventricular arrhythmias or atrial fibrillation, to make sure you're managed appropriately. And we also need to make note and communicate to your obstetrician what kind of device you have, and this should be part of your delivery plan. So whether you have a pacemaker or a defibrillator, whether you're dependent on pacing, meaning you're pacing almost all of the time, whether you have a unipolar or bipolar system, this will have an important implication for how we're managing your device if you need cautery, for example, and whether your ICD was planted because your doctors were worried about you, or whether you have an ICD implanted for secondary prevention, meaning you've already had a cardiac arrest or some very bad heart rhythms, and that's why you have a defibrillator. This will give us a better understanding of what your underlying risk is of arrhythmia. We often will recommend a magnet under certain situations. A magnet will stop your defibrillator from sensing arrhythmia and from delivering therapy. So this may be important if you're needing a lot of cautery, for example, in a cesarean section. A battery or a magnet may be placed over your device to stop it from sensing that electrical interference. A battery will also force your pacemaker to pace. So cautery, for example, will not turn off pacing if you're pacing dependent when we place a magnet over your device. However, if you have a defibrillator, a magnet will not force pacing. So these are important things that your obstetrician needs to know before you go into labor and delivery. In terms of family planning, we discuss this with our patients from a pretty young age after they transition to adult care, mostly reassurance and education. It's safe in almost all of these cases to plan a family. There are some disease-specific risks and concerns like cardiomyopathy with heart function, higher risk long QT subtypes, for example, long QT type 2, which I discussed at the very beginning. And again, this is something that Anna is going to discuss. So genetic counselors available in our clinics to answer questions, to educate about transmission of these genetic traits. And in preparation for pregnancy, we look at medications, make sure you're on safe medications for planning pregnancy and subsequent breastfeeding, if that's something that you're going to choose, and also discussing genetic testing, if this is something that has not already been discussed with you, and also device surveillance in situations where women have a pacemaker or defibrillator, again, to make sure that it's working properly before you are heading into planning a family. It's important that if you're planning a family, that this is something that you discuss with your doctors to discuss medication safety, what medications you're using in pregnancy, whether you're taking anything, for example, like an ACE inhibitor for cardiomyopathy that may not be healthy for the fetus. making changes to medications prior to pregnancy when necessary, and again, reviewing potentially harmful medications, so things that you should be avoiding in long QT syndrome or Brugada syndrome. Again, reminding you about compliance with medical therapy and the importance of taking your beta blocker and the safety of using a beta blocker in pregnancy. We also want to monitor to make sure that you're adequately treated as you're, in pregnancy, as you're growing and gaining weight and increasing your blood volume. Your need for beta blocker may also increase. It's also important to know what your options are for genetic testing and the options for cord blood testing, and also to allow us to make a liaison with your obstetric team to discuss the need for fetal monitoring. And again, a lot of reassurance, I think, is needed for the obstetric community to know that you're going to be safe to have a baby, and also to make the safest plan for your labor and delivery. Again, it's important that we make a labor and delivery plan, and it's something that you should have in writing, and something that I try to provide to all my patients in writing, to know contingency planning, the importance of beta blockers, the need for monitoring if you're in a situation that's quite uncommon, that you will need cardiac telemetry. Again, to remind your obstetric team of which medications will require some caution in long QT syndrome and Brugada especially, the need for telemetry. So if you're a higher risk patient who's going to need closer cardiac monitoring, and again, decisions around cord blood testing and mode of delivery. And again, it's important that we remind the obstetric team very, very often that assisted labor and delivery is rarely indicated in these primary arrhythmia syndromes. So that brings me to the end of my slides here. So I'm going to pass this on to Anna, who I think or Dr. Strasberg is coming up next.
I believe I'm next.
Yes, Anna, go ahead.
Sorry.
Okay. Can you see my slides? Here we go. Can you hear me well?
Yes.
Thank you, everyone, for the invitation. And Dr. Spears, that was excellent. Thank you for laying the ground for my part of the presentation, which will focus on genetic counseling for pregnancies with a SADS condition. And before I get started, I'd like to disclose that I'm an employee and shareholder at Invitae. In genetic counseling, we attempt to answer two key clinical questions. Can a genetic predisposition to a condition be identified? And what is the possibility that it may happen again in a family member? And importantly, the preconception period is the preferred and recommended period to address these issues. The genetic counseling toolkit has 4 key components: medical and family history, genetic testing, and psychosocial support. And I will be addressing this at a high level and how they apply to pregnancies with SADS conditions. In terms of medical history, we usually do this in collaboration with a cardiologist and a nurse, with the goal of determining if disease symptoms or risk factors are present. Important information that we gather includes a history of prior cardiac arrest, any concerning symptoms, ECG findings, if there is a known diagnosis of heart disease, including prior genetic testing results. Pregnancy history and information about current medications is also obtained during this portion. We also go over family history. And here we attempt to answer, does a heart condition run in the family? And if so, on which side? Has genetic testing been done, and in whom? Could the pregnant woman be at risk for that particular mutation identified in the family? If so, what factors such as family dynamics may influence risk perception and decision making? And can we refine suspicion of a genetic predisposition and risk assessment? So refining suspicion while taking family history requires knowledge about inheritance patterns. And one key message today is that most SADS conditions are inherited in an autosomal dominant pattern of inheritance. In this pattern, only one copy of a mutation indicates needs for surveillance for heart disease. And that also means that the first degree relatives of somebody who has that genetic predisposition will have a 50-50 chance of also having the same mutation and will be at risk for developing the same condition. If you look at the picture on the right, we have a family, and in this case, dad has a mutation as shown by the shading in blue, and he passed on the mutation to 2 of his children. One of them is a daughter, and this information could be highly relevant to a pregnancy. One key aspect to remember is that while most SADS conditions are autosomal dominant, we also see autosomal recessive and de novo inheritance, although less commonly. And in these cases, as opposed to, for example, in autosomal dominant inheritance, where we tend to see the condition in every generation in the family, we will not be observing the condition in every generation with these less common patterns of inheritance. It may appear sometimes that the condition is isolated, and it's important to remember these caveats because we don't want to be influenced incorrectly to rule out a genetic predisposition. So one key aspect in the genetic counseling investigation is to review all the data, medical history, family history, and also use genetic testing as a tool to gauge where we are in the genetic risk assessment. And genetic testing is relevant when we talk about pregnancy because it could provide an opportunity to optimize management and therapy. As Dr. Spears explained, there are certain types of conditions and specific mutations that may put someone at higher risk for complications. For example, KCNH2 mutations with increased risk for postpartum events. And also, of course, family risk management is enabled by using genetic testing. And the testing can be done in different ways, different modalities, and we go through all of these choices in our sessions, and everyone will choose something different depending on their situation. But it usually starts with mom in this setting, and it would be indicated when there are signs and symptoms that indicate a suspicion for a SADS condition, or if we know that there is a mutation already running in the family for which we should be offering testing to the woman. And this testing can be done either by blood or saliva testing. There's also genetic testing for the baby. And in the usual workflow, when we're dealing with pregnancy, it usually starts with mom being known to be affected or carrying a mutation. And in these cases, we have to think about testing for the baby. And let's not forget that the predisposition may also come from dad, and may also put the baby at risk. But in either case, it's important to consider testing for the baby. And sometimes fetal testing, as Dr. Strasburger will be explaining in her portion. And this is because fetal long QT syndrome has been documented, and many of these arrhythmias have early onset in infancy or during childhood. Sometimes women want to know about fetal testing that can be offered while they're still, carrying their pregnancy. And we have two main modalities: amniocentesis, shown on the right. It's usually done during weeks 15 or 20 during pregnancy, or chorionic villus sampling, or CVS, which is done earlier between weeks 10 and 14 of pregnancy. And these are invasive procedures. And one key aspect here is that we don't offer prenatal testing, fetal testing, unless we have a mutation that is known to be confirmed to be responsible for disease in the family. We want to make sure that if we go in with a procedure like this, that we have high confidence that we are actually running informative testing with helpful results. Sometimes families decide to wait after the baby is born, and in this case, we can do cord blood testing or wait until infancy or later in childhood to do the testing. The psychosocial aspects is part of what genetic counselors spend a lot of time with patients in this setting. We know that there are recurring issues that come up, and we provide ample space to explore them. We know that there is anxiety, sometimes over passing a disease risk to a child, concern about their own pregnancy health, uncertainty about what may happen in future pregnancies. We also make sure that any decision made is done in a patient-centered manner, taking into consideration beliefs, values, experiences, and everything done using a team-based approach with the cardiologist, the obstetrician, the family, the pregnant women in front of us, so that we reach the best decision together. And also normalizing and supporting a healthy pregnancy is so important. Unfortunately, so many women are miscounseled about risks when they may carry a predisposition to one of these conditions or are affected with one of these conditions. But the truth is that if there's, in the absence of advanced heart failure and with good arrhythmia control, a healthy pregnancy is possible. And this message can be transformative. I often think about, how many women may actually, and Dr. Spears alluded to this in her presentation, go into a pregnancy or the postpartum period with a genetic predisposition but not know about it. And I believe that there is ample opportunity to collaborate with our prenatal colleagues to identify women who may develop a SADS condition. So here are some red flags that we should be aware of. In personal history, recurrent complaints of palpitations and unexplained fainting deserve attention, especially in the setting of a suspicious family history. In fact, I believe that a family history should be obtained from all pregnant women to identify red flags that could, identify an opportunity to provide special care. Things like unexplained sudden death or cardiac arrest at less than 40 years old, fainting without warning triggered by exercise or a startle, chest discomfort or shortness of breath, reports of ICDs in the family at less than 50 years old, reports of SIDS, unexplained accidents, sometimes drowning or single car accidents could actually be the result of an arrhythmia. Seizure events and vasovagal syncope can actually be an arrhythmia, be misreported as something else. We also pay attention to extracardiac findings. So for example, deafness in some cases may indicate suspicion for a specific type of long QT syndrome. And of course, the presence of multiple similarly affected family members. And as I said at the beginning, the preconception period is the preferred period to address these issues because it allows ample opportunity to explore these issues without the constraints of fetal testing or an actual pregnancy happening in the moment. We can work on risk reduction by identifying the appropriate drug therapy. We can take our time in doing family genetic studies and identify the right marker if we want to do fetal testing or testing early after the baby is born. And it also opens the opportunity for pre-implantation genetic testing, or PGT, which is what I show on the right here. This is a procedure where we test embryos fertilized by IVF and will biopsy a cell from that embryo and will look for negative genetic testing results in an embryo. And only the embryos that are negative, that did not inherit the family mutation, are implanted to pursue a pregnancy. And what makes this procedure attractive is that it circumvents the often difficult decisions that are surrounding fetal testing during pregnancies. It has been done for SADS conditions, although it's still quite rare as a procedure. When we talk about genetic testing and genetic counseling, frequent questions come up, including those about cost or insurance or where to find a counselor in someone's particular area. And I find this website, aboutgeneticcounselors.com, from the National Society of Genetic Counselors, to be very helpful. It has very good information with frequently asked questions, and also a directory where someone can find a genetic counselor in their area. I will close by thanking my colleague, Julia Wilkinson. She's a reproductive genetic counselor working with me, who was essential in helping produce this presentation. And my contact information is here in case you have any questions or I can help with anything. Thank you very much. I will pass it on to Dr. Strasburger.
Thank you, Anna. I'll give Dr. Strasburger a moment to share her screen. Very good.
Okay,
now
I'm unmuted now. Can everybody hear me?
Yes, you're good. Thank you.
So I'm going to be speaking about managing the pregnancy with inherited rhythm disorders from the baby's perspective. And for many of you who've been to Door County, you'll notice this road at the very tip of Door County, which signifies that it's often a windy road when you're pregnant and you have a family history of long QT syndrome or one of the inherited channelopathies. So I do have a few disclosures. First of all, Dr. Ackerman, we need pictures. Second, we do have grant support and have since 1998 for the research that we're doing, and it supports the travel costs not only of the pregnant patient if she wishes to come, but also of her partner or a companion. And that's true if we need to fly them here once or twice or beyond that. So I think that it's very possible. We wish that the type of testing we did was available in every center, but until we develop some more new devices that are less costly than the ones that we're using now, it's probably going to remain trapped in the physics lab at UW-Madison. I think within 3 years, though, that we will. I also am on a writing committee, and I just wanted to mention that this year the Heart Rhythm Society is putting out a consensus statement on arrhythmias in pregnancy, so you'll want to review that once it comes out. So this is who we are. Gretchen and I and Patrick, our biomedical engineering student, we commute from Milwaukee over to Madison for the research. And we work with a very talented scientist, Dr. Wakai. And the medical physics group at UW is famous for providing inventions like tomotherapy and digital subtraction angiography. And these are used in every cath lab and used for radiation oncology. And we think ours is an invention that's very important too. I just want to touch on this, though, that obstetrics really does not get the innovation that other specialties get. For every $1 billion invested in obstetrics, there's $23 billion invested in cardiology and $334 billion invested in other medical specialties. So as an area of prioritization, I think this is one, because we do need to be able to make diagnoses. Unfortunately, because of the uterus and the vernix, which is the white stuff that surrounds the fetus, the electricity cannot escape from the uterus. And so we can't just put stickers on the mother's abdomen and be able to record an EKG. But we have the second best, which is that we can record the magnetic signals coming from the heart naturally. So this is what's called a squid magnetometer, and it is FDA approved for use in the fetus, and it's had a high score from the AHA, and saying that the benefits far outweigh any risks. We can study patients anywhere from 15 to 40 weeks gestation, and it's really just a listening device, kind of like an EKG. It is done in a magnetically shielded room, but in this case, the shielding is actually to keep the noise on the outside so that the room is clean of any electricity or magnetic signals. And that allows us to record these very minute, tiny signals. And when we get them, they're a little noisy, like you can see on this graph below, but we are able to process them using signal processing to remove that noise. We have a new device. This is kind of a prototype, so I apologize, it looks a little bit crude, but this is a new device that is only about 1/10 the cost of the squid magnetometry, and we think will be FDA approved soon. We're working with a company to hopefully begin to get this ready for marketing. And it's if you do come to Madison, you do not have to participate in this portion of it. You don't have to use a device that's not FDA approved. We make all of our clinical diagnoses on the basis of devices that could otherwise be used. One of the problems is that insurance doesn't often cover new devices, and so we've kept it under protocol in order to offset the cost for patients who come, because most young families can't really afford to be traipsing all over the United States for testing. So I wanted to just talk a little bit about bravery. Many of you may have heard Susie Burnt when she was on with Mike Ackerman last week, and Susie made a trip with her family out to Madison and early last year, and on the second visit, the travel bans were being instituted almost as she was arriving. And the day that she came for her second visit, in order to assess medication responses for the baby, the entire system of research at UW closed down and remained so for the next 3 months because of COVID-19 pandemic. And so I think she deserves a cheer for what she did for her baby. But little did Susie know that just 1 year later, she would have Gabby. And Gabby is going to be from the class of 2040. She's already, as you can see on the page OP, which stands for optically pumped magnetometry, and she's going to join us when she grows up. So long QT presents in the fetus a little differently than in the infant. Stillbirths are probably a little more common as are miscarriages in pregnancies associated with long QT and other channelopathies, but this may be because they have not been proactively managed with nutrition and other things that we've learned along the way help with reducing these risks. In the fetus, the placenta actually works. Torsade is a very fast rhythm, as you can see here, but the placenta actually works. Hang on, I'm needing to go backwards here. It works almost like a heart-lung machine would work during heart surgery. It protects the fetus by keeping the blood pressure up during torsade, the rapid rhythm. And so the fetus can tolerate torsade a lot longer than at other ages. In fact, in an infant, they might develop cardiac arrest or low blood pressure. The fetus also seems to tolerate low heart rates better than infants. And in infancy, often a pacemaker is put in at birth. And I think Susie said herself that she had had a pacemaker put in right after she was born for a low heart rate. In the fetus, when hydrops develops, which is a sign of heart failure, we can sometimes reverse that by treating the mother, by giving the mother medications that treat the arrhythmia. So as I mentioned, these are two of the arrhythmias that we see, and the one on the top is 2-to-1 heart block. So the atrium is the downward deflection, and the upward deflection would be associated with a pulse or an output from the heart. And so the rate here is about 60 beats per minute. So I wanted to just review our experience that we published last year in JACC-EP on 39 cases of fetal QTC prolongation. This represents the patients that were positive. We actually have assessed almost that many again that were negative for long QT. Most of the patients we saw have been familial cases. And in that group, we have had no mortality in the group of 27 patients with inherited long QT. We have had some mortality in those that are de novo cases, but again, this represents looking back over a decade, and we think that some of what we've learned in management will be helpful in preventing these fetuses. The other thing is that it's very important to begin treatment before the hydrop develops. So early referral is often very helpful for us. We have not seen any ARVC, as Danna suggested. It's more of a maternal disease. We have seen, we've tested 3 cases of Brugada, but only 1 showed the classic findings. The other 2 were genetically negative. With the long QT, we've seen all various types of long QT. So this is a fetus that has torsade. So at the top, it's a little, I'm sure you're not used to looking at this, but the heart rate here is 50 to 100, and it's a little over 50 beats per minute. So when this patient came, the heart rate was slow, and that was the reason for the referral. They actually had not detected that this torsade was happening. And so we found this rhythm and were able to start mom on medications. And she came back 4 weeks later or 5 weeks later, and the second degree block or the slow rate was still there, but you can see that there's now only just little tiny bursts of torsade, and they seem to be with exercise, which is kind of what we see postnatally as well. So what are some of the warning signs that your baby might have long QT syndrome, especially a more severe case of long QT syndrome? The first is that the heart rate may be slower than expected, and it's important for the obstetricians to not just check off that the heart rate is present, but also to write down what the heart rate is. And if it's below gestation norms, as shown on this graph, I'm sorry, I can't really see the graph very well because I'm looking at okay, there. So this lower line here is the 3rd percentile. So anything below that would be considered abnormally low for gestation. And in this case, you can see that most of the long QT cases were actually below the 3rd percentile. But 110 beats per minute is kind of where the obstetrician begins to worry that there might be bradycardia. And in that setting, basically all of these cases would be missed because they're not below 110 beats per minute. So we think that with education of our obstetrical community and proactive assessment of your own pregnancy during, with a family history, that you should be able to determine if the rates are lower than they should be. And then we can do the diagnostics like we do in the lab. The other thing would be if there's a slow rate, like less than 75 beats per minute from 2 to 1 block, or early heartbeats, or the most severe is tachycardia, which is a racing heartbeat that's very fast, and that's usually torsade. But we also have seen atrial flutter in more severe cases of long QT syndrome in the fetus. And then finally, hydrops can occur if this becomes advanced, and so we usually like to hopefully catch it before that time. So the timeline then again, remind your OB to check heart rates, and they are usually starting to drop, especially in LQT1 and those that have a double mutation by about 15 weeks gestation. And then a lot of the arrhythmias come on around this time, 19, 20 weeks and on. If torsade is found, we do treat it, and we either have to start the mother on a beta blocker, or if she's already on the beta blocker, sometimes we will switch to one that is the best absorbed for the fetus. And so propranolol tends to be the best absorbed for the fetus. And then, of course, the problem that we have by doing early testing is that there are some long QT cases that come on during 20 and 20 to 27 weeks. So we usually will consider what we find in the lab as being over 90% diagnostic after 27 weeks. But before 27 weeks, if you test negative, you may have to come back again in order for us to retest to be sure that the baby really doesn't have long QT. Because like I said, there are some that present late in fetal life. And then, of course, with delivery, I won't go into that, but it is a time that monitored deliveries may be needed. And I think Danna covered that very well. So our principles of treatment are that adequate nutrition, especially for magnesium, calcium, potassium, and vitamin D, is crucial. We have seen fetuses that are low in these minerals turn around overnight with replenishment of low levels of any of these. And so we're very cognizant about that. And if you are thinking of getting pregnant, you should probably check your vitamin D levels before you have the pregnancy. I would check a 25 OH. There is another one called a 125, but that's not the right one. So the 25 OH should be above 30. And so, again, we use, these are sort of nature's antiarrhythmics, and they work very well. Avoid QT prolonging drugs, have a knowledgeable provider. If you can come to Madison, it's good. We can hopefully tell you if your baby does or doesn't have long QT syndrome, or another, we think another ion channelopathy. We're not sure how accurate we are for things other than long QT syndrome. Transplacental therapy is when we give the mother medication to treat the fetus, and in that setting, it can be life-saving. And the one thing I wanted to point out is that sometimes dad has the long QT, or a sibling has the long QT, and it's still important for the mom to not take medications that lengthen the QT interval, at least until we know if the baby has long QT or not. So that would be things like Zofran. So in summary, with the family history of long QT, the prognosis is really pretty good. There's still some caution in the rare de novo LQT3 or SCN5A defects, where we really need to work hard on getting a better management strategy in place. Transplacental treatments with beta blockers, lidocaine, and magnesium when it's necessary, and for torsade, have been very effective. And it should be even considered close to term, because it's probably safer and easier to initiate a beta blocker in the midst of torsade in the fetus, where the placenta is helping maintain blood pressure, than it is in the neonate, where the torsade can be very symptomatic. The QT shortening after birth is seen in about half of all LQT1 patients. They usually have shorter QTC intervals anyway, LQT1s do. And so about half of them shorten, but in almost all the other more severe types, the QT does shorten. So that's actually a positive thing, that you can see some improvement in QTc after delivery. And with the severe presentations, the postnatal treatment is often a combination of a pacemaker to increase the heart rate and a beta blocker for rhythm control. So I'm going to end here, and I think we'll take some questions. I just wanted to point out too that none of the figures and things that I showed were from Gabby. They were from other patients. So thank you for letting me speak here.
Thank you, all three of you, for some wonderful presentations. And yes, now is the time to ask your questions, and you may turn your camera on and you can unmute yourself and ask your question verbally if you like, or you can put your question into the chat field and indicate to whom you'd like that question directed. And congratulations, we do have Susie on the webinar, as well as her mother, Barbara. So welcome, and what a cute picture of Gabby that you shared. That was,
it really was
adorable. Okay, any questions? Please put them into the chat or unmute yourself and turn your cameras on. We'd love to see your faces. That'd be wonderful. Yay, Katie, thank you.
Hi, so I have a question for Dr. Spears. I'm actually, I'm 9 or 8 months, I think like 37 weeks next week gestation at this point. And I guess my big question is, you had talked about oxytocin or Pitocin being used in some of the cardiac conditions, but not necessarily with long QT syndrome. I am LQTS positive, genetically confirmed KCNH2. Thank you, Invite.
Yeah, so that's, can you hear me? So that's a very good question, and that's a sensitive topic I find when I discuss this with obstetricians. So oxytocin or Pitocin is one of the drugs that are listed in Credible Meds as being potentially QT prolonging, and indeed there are case reports of it causing QT prolongation. And so when I am discussing a management plan, I do make sure that the obstetrician is aware that this medication can cause QT prolongation. And so in women who have a baseline of a QTc that's greater than 500, that woman is generally perceived to be at higher risk. And so I do recommend more serial electrocardiograms or even cardiac telemetry, if that's available in the center that you're at, to make sure that you maintain your beta blocker, that your electrolytes, so potassium, magnesium, those are the ones that tend to become a little bit lower, especially in pregnancy. So to make sure that those are adequately replenished when you are presenting to the hospital in labor, so that you are sort of stacking all of the odds in your favor in terms of your QT interval. So I would never say don't use oxytocin, because we know that this is an important intervention to help labor progress, delivery, and also to reduce postpartum hemorrhage and bleeding. So it's important. It's an important part of your obstetrician's arsenal, but you're absolutely correct, and that is something that your OB should be aware of to get an ECG at baseline, and then I do recommend an ECG after the oxytocin has been initiated to look for whether there's been a dramatic increase in your QT interval. And if there has been, then that's another time to check, do you need some more potassium, some calcium, or magnesium to make sure that we're optimizing everything that we can. The risk is low of having an arrhythmia, but obviously our objective is to keep you as safe as possible with a little bit of additional monitoring while you're being exposed to oxytocin. So that's absolutely true. You're totally right. Does that answer your question, Katie?
It does, and you see my little OQTS baby in the background too.
Oh, I saw a shy one too.
Thank you for sharing and asking a question. Any other questions?
Hi,
Ariana. Hi.
I have a question. Oh, I just realized about my background. Sorry.
Hi.
I had a question about, so if it's pre-pregnancy, when do you recommend, like we've already been genetically tested, we've already had all of our sequencing and I'm on beta blockers. When do you recommend starting workups, I guess, to get a first evaluation pre-pregnancy, if that makes sense?
A genetic evaluation or clinical testing?
I get clinical, just I guess this is kind of to, I'm not sure to everyone who spoke, but maybe Dr. Strasburger, I'm not sure who's the best person. Like, do I still go get genetic testing again pre-pregnancy?
I think if you've had genetic testing done and you know your genetic type, then we would assume that the baby probably has a 50-50 chance of having the long QT. And as far as the optimization of your nutrition, I would start about 3 months before with combination of folic acid, vitamin D. A lot of people don't realize that they do not put a lot of calcium and magnesium in prenatal vitamins. And the reason for that is because it causes GI distress. And so you can't really rely on your prenatals to get your calcium and magnesium each day. And you need about 360 milligrams of magnesium a day and about between 1,000 and 1,200 milligrams minimum of calcium a day. So if you're drinking your 4 milks a day, you can get that, but a lot of women are intolerant of milk and can't. So it's good to find us, a substitute for that. You're welcome to, contact my nurse, Gretchen, who's on the call here, and she could send you some of the handouts that we use for from the NIH for foods that are rich in calcium and magnesium. And usually if you're getting enough calcium and magnesium, you're getting enough potassium too. But sometimes in that first trimester, if you're losing weight and you have hyperemesis, that can be another danger time for you. So you should put a plan in place with your obstetrician of how long, how much vomiting, how much weight loss is he going to tolerate before you go in for IVs to replenish your electrolytes, because you don't want to get too far behind and end up with a syncopal episode. So I hope I answered your question. I'm sure there's other questions for, parts of this question for Anna and also for Danna.
Thank you.
Would you like to add anything, Anna or Danna, for Dr. Spears?
Just one bit. I think Eliana also asked about, will I need more genetic testing during the pregnancy? Did I hear that part of your question correctly?
Yeah, I didn't. We did that, 20 years ago, and I wasn't sure if I'm supposed to redo any of that beforehand.
It would be a good idea if you go early, as Dr. Strasburger suggested, to bring your genetic testing results to that consult, because if it was done 20 years ago, things have changed dramatically. We want to know that you had the right number of genes tested, that the result was properly interpreted. If it has to be repeated, it should be repeated. It may not need to be repeated. But the other thing to add is that every pregnant woman gets offered genetic testing for other conditions during their pregnancy, carrier testing and other types of testing for the baby, where an additional test for cardiac disease or long QT may be added to the options for you.
Thank you very much.
Thank you. Any other comments, questions?
Hi, I had a question for Dr. Spears. I am long QT1 and I've been asymptomatic like my entire life. I take Nadolol, the 40 milligrams, and I am 30 weeks pregnant with my first baby. So the plan right now is to be on like telemetry for the birth. But also they want to induce me. And so I'm glad they asked the Pitocin question, because that was part of my question too. But I don't remember on your slide if in long QT1, like without arrhythmia or any kind of symptoms, is that necessary? Or just like, what is your experience around induction? And I guess that's my question.
Certainly. So that's an approach that is commonly used here as well, because we're an enormous province with a lot of women who are not near a major urban center. And so sometimes, just so that we have a predictable planned delivery rather than on a highway in the middle of the night, we do have a lot of women who are induced. And Pitocin or oxytocin is an important component of that to augment labor. And so, you know, there was one case report that I can think of where oxytocin caused QT prolongation and arrhythmia. This woman was not on a beta blocker, so it sounds like you're being very well managed. And you know, that's our goal, is to make sure that you're adequately beta blocked through pregnancy, labor, and delivery and beyond to prevent these sorts of complications from happening, so that your OB can just focus on you and your baby and not have to think about all of these other things, because really the risk during labor and delivery of arrhythmia complications is extraordinarily low for you. And so, you know, you're going to be on cardiac telemetry, it sounds like, so someone will be monitoring your heart rhythm. I think it's not unreasonable to get a baseline ECG and just, you know, make sure that, you know, your QT interval is not 550 milliseconds when you're heading into this you know, endeavor with oxytocin and whatnot. And as Dr. Strasburger mentioned, making sure that your potassium, calcium, magnesium, vitamin D are as replenished as possible will sort of, you know, put you in the best possible situation before you go in for delivery. But otherwise, you know, this is a very common approach and strategy for delivery. And I've seen, honestly, no issues with this at all. And it sounds like you're being very, you know, well managed regardless. So it's sort of as a precaution. So I don't see any issues with that at all. Does that answer your question?
Yes, thank you.
Perfect.
I just had a couple of comments. One of the medications that helps women who are not breastfeeding to withdraw from lactation is also on the long QT list. So always be careful if you are getting a medication to, you know, and if you choose not to breastfeed. And then the other thing is that I think a lot of women are told by their obstetricians that the reason that the baby's heart rate is low is because of the beta blocker, but really the beta blockers have very little effect on the heart rate, only about 7 to 10 beats per minute. So, you know, they might reduce the heart rate from 140 to 130 at the most. But if your baby's running heart rates in the, you know, 120s, 110s, 105, it's more than likely due to long QT syndrome as opposed to being due to your beta blocker.
Okay, thank you for your responses. And Jordan has put a question into the chat field. Is an epidural contraindicated for SADS, specifically symptomatic ARVD?
So I'm happy to answer that one. So, so specifically for ARVD, no, I have no concerns about that choice for epidural anesthesia. The one condition where it does become a bit of a concern is Brugada syndrome. And in those situations, often a spinal anesthetic will be chosen because much lower doses can be used compared to the dose of local anesthetic used in an epidural approach. But again, it's not contraindicated. It's just something that should be discussed with your OB and anesthesia team. But for ARVD, absolutely not. I don't see any reason why that would be an issue. And to contrary to that, it would actually reduce, potentially your level of stress and catecholamines, et cetera, in terms of keeping you comfortable for delivery. So I would have no concerns about that from a cardiac perspective.
Thank you, Dr. Spears.
I have one more comment, and that is that in our study, we did not see any long QT1 patients that had torsade in the fetus. We did see some, just I think 1 or 2 with second degree block, but the arrhythmias in the fetus tend to be a little more mild with long QT1. And at least at this point, we haven't seen any torsade. Overall, though, with all types of long QT in the inherited form of of long QT syndrome, we've seen about 12% with Torsades. So it's not like it can't happen. It's not nearly as high as in the de novo, but it's definitely a possibility, and more so with either double mutations or when there's a different type other than LQT1.
Thank you, Dr. Strasburger. Any other comments or questions from anyone? Okay. Well, then I would like to thank our presenters, Dr. Strasburger, Anna Morales, and Dr. Spears for your excellent presentations. And I will thank everyone for joining us tonight. Have a good evening.